let me introduce Dr. Ryan Bailey, who's our third-year family practice resident from St. Lucie Medical Center, who's going to present a fascinating case that he saw two weeks ago, I think. All right, Ryan, you're up.
Hey. Here we go. Can everyone see the slide okay? Okay. Greetings, everyone. Thank you for coming. My name is Ryan Bailey. I'm a resident at St. Lucie Medical Center. So we get to spend about 4 weeks here at a time, which isn't a lot of time, but it's enough time to see how things go here, what you're able to offer people that we can't do in like a normal medical model. It's been a lot of learning on my part to see what's available here. And I thank you all for being welcoming and helping me have a good experience here. I've been helpful as well. So this is a patient I saw here who has a very rare genetic syndrome called Ehlers-Danlos Syndrome. And he had some complications from that we'll go into. This is just an overview of the case from when I saw him here in the office. He's 24 years old. He has a known history of Ehlers-Danlos, and this was his first visit at the clinic here. So he was recently admitted to Lawnwood for about 6 days last month. And the reason being, he went to the hospital with new lower extremity swelling on both sides and intermittent shortness of breath, worse with exertion. And they basically found to be an acute heart failure, which was a new diagnosis for him. So at Lawnwood, he had a BNP elevated at 452. That's a marker for heart failure. He had bilateral small pleural effusions on the CT of the chest, meaning fluid in the lungs. His echocardiogram, meaning ultrasound of the heart, showed a ejection fraction that was reduced 35 to 40%. And he had some valve abnormalities, to say the least. Mitral valve prolapse and regurgitation, and tricuspid valve prolapse. And both valves were described as myxomatous. I'll get into what that means exactly later on. So Dr. Heitman is the cardiothoracic surgeon at Lawnwood. He recommended to repair those valves, which has not been done yet. It's kind of in the process of getting organized because we need some other things done first, and we'll get into that. He was discharged with Lasix 20 milligrams daily to get off the fluid overload from the heart failure. So when I saw him here, he was saying he was having no shortness of breath at all. His swelling in his legs had resolved completely, and he was still on Lasix 20 milligrams daily. Otherwise, in his history, he had a bilateral hip joint replacement when he was 17 and 18. The surgeries were done separately. And then his mother also had the same genetic syndrome, and she had an aortic valve replacement and total tooth extraction and suffered from hearing loss as well. Lasix was the only medication he takes right now. Doesn't have any known allergies, and he never smokes, occasionally uses alcohol, denies any recreational drugs. So this physical exam, vital signs within normal limits. Physical exam significant for systolic murmur at the sternal border. Poor dentition overall with a lot of crowding of the teeth together. And then, he had the previous bilateral hip replacement. And I just noted that his legs were kind of bowed outward, which is known as a varus deformity. And so he did limp a bit. from that. These laboratory results were from Longwood when he was admitted there. So his hemoglobin just a little bit low. His liver enzymes a little bit elevated. And like I mentioned, the BNP is a marker for heart failure. That was also a little bit elevated. And then his COVID swab was negative and his blood cultures were negative. Imaging done at Longwood. There was no abnormality noted on the chest x-ray. He had a CT of his abdomen and pelvis. They said he might have cystitis possibly just based on the visual, but he wasn't having any other symptoms, so it wasn't treated. And then he had the small bilateral pleural effusions, meaning fluid in the lung space. And they did ultrasound of his legs to rule out any kind of blood clot. Due to the shortness of breath and leg swelling, they didn't find any blood clot. And then he had the transesophageal echo, which is the ultrasound of the heart. His ejection fraction was reduced. And then he had those valve findings that I mentioned before. So going into a little bit to what that term means, myxomatous cardiac valves. It is a term to denote a progression of valve structure caused by defect in the overall mechanical integrity. So in this case, with Ehlers-Danlos, collagen is affected because of the genetic abnormalities. And over time, there'll be increased volume and thickness of the valve leaflets. And then the chordae tendineae are little string-like attachments that are connected to the valves. Those can also become thickened and are at risk of rupture. So it just has to do with the genetic abnormality itself causing the defect in collagen, and over time, the structural changes that happen in the valves cause them to not work as well. So this is, I'm not a dentist. I don't know if we have any dental people here.
They're online.
Okay, great. I just put this up as a comparison for the next slide, which is our patient. The next slide, this is kind of a Google search of a normal panoramic X-ray. And then I'll just go forward. This is our patient. So what I noticed, again, I'm not a dentist, is that overall, compared to the previous slide, these teeth are very straightly aligned and have normal spacing relative to each other. These teeth are more crowded and misaligned. And then I think I noticed some broken teeth, back here on the X-ray. So just to recap the overall assessment and plan for the patient. He's 24 years old. He has Ehlers-Danlos Syndrome. He was here to establish at the office. We went over his hospital admission to Longwood for acute heart failure from mitral valve prolapse and tricuspid valve prolapse. So the plan when he was being discharged was that, just like his mom had needed to have done previously to have total dental extractions. Once someone has a heart valve replaced, they're at a much higher increased chance of endocarditis, which is an infection of the heart valve, which can be seeded by dental procedures in general. So it's a good idea if someone is going to need a lot of dental procedures to try to get those done before a heart valve replacement, if possible. So that's kind of where we're at right now, trying to get all that organized. He is higher risk due to his genetic disorder and his known heart problems. So that we're trying to get that done in Longwood. So has better monitoring of his medical condition in case anything goes wrong, of course. he would be in a better place to deal with it rather
Will
than
they,
just in the
do they do
office.
dental surgery in the hospital?
We'll go over that later.
And then after that's done, he can be evaluated for the valve repair from cardiothoracic surgery. Plan was to continue his Lasix until otherwise specified by the cardiologist, to follow up his elevated liver function tests. We don't necessarily have a reason for that at this time. Sometimes they can just be elevated with heart failure as fluid kind of gets backed up, or it could be for a different reason. And then ophthalmology monitoring, which is something that all of these patients need.
You might want to add the symptom of his eye. Have you talked about that?
No.
Because I follow up for that. So just
Okay.
why the ophthalmology referral? Remember what the symptom was? He noticed some blurring and loss of vision
Okay.
in one of his eyes, which was new.
Okay. So for those who maybe couldn't hear, he had blurriness and kind of a change in vision in one eye. We wanted to get that evaluated. Just going over Ehlers-Danlos syndrome. It's a fairly rare disorder. It's characterized in general by skin hyperextensibility, joint hypermobility, and fragile tissues. The overall prevalence of EDS is 1 in 5,000 roughly, but there's 13 different subtypes. So of those subtypes, hypermobile is the most common, 1 in 10 to 20,000. Classical type is the second most common at 1 in 20 to 40,000. And then third most common is vascular EDS, which is what our patient has. And that's 1 in 50,000 to 200,000 of the general population. And that has to do with specifically with type 3 collagen. Overall features that are mostly in common through the different subtypes, or that you might see in different subtypes. Again, the hyperextensibility, joint hypermobility, I just put up there exactly how that's measured clinically. These different tests of dorsiflexion of the fingers greater than 90 degrees backwards, apposition of the thumb to the forearm, hyperextension of the elbow past this level of 180, hyperextensibility of the knee in the same way, and if you can put your palms on the floor with the knees fully extended, bending down. So I don't know if I can do any of those things. These people tend to have a lot of joint injuries or musculoskeletal injuries from the laxity. They can get premature arthritis at a younger age, or at risk for different types of dislocations. They can have flat feet, deformity of the chest wall. They can have resistance to local anesthesia. They can have nearsightedness or risk of retinal detachment. Studies in the past have always linked this with mitral valve prolapse. I did read some other studies saying that it's actually the same as the general population in terms of that risk, but I would say this is the one patient I've ever seen with this problem, and he happened to have mitral valve prolapse, so it seems like a pretty good association to me. And then they're also at risk of spontaneous pneumothorax. Going over the overall genetics, they're caused by inherited alterations in specific genes affecting synthesis and processing of different forms of collagen, which is present throughout basically the entire body, organs, skin, tendons, ligaments, and vessels in the eyes. So some forms are inherited on the autosomal dominant pattern, some are recessive. So I just put up the classic Mendelian genetic thing there, which was first done on pea plants. So he would measure, breeding different pea plants with each other, what happened with their offspring. So the colors, either pink or white. In this case, the white would be the recessive, and the purple would be the dominant. So in a recessive pattern, both parents need to contribute that gene, where in the autosomal dominant pattern, it can just be one parent. And then there's also, in addition to those patterns, the chance of a spontaneous mutation, meaning neither of their parents have either of these genes. It's just something that happened to mutate, and it's a new first generation diagnosis. So I know this is very small and impossible to read. It just goes over the different 13 subtypes of EDS, and what they're called and what gene they're associated with, and some of their predominant features. So in our case, our patient, if you go through all of these different features, he has some from different forms that would be associated. But we already know he's in the vascular category. So on that one, it says features are risk of arterial rupture, internal organ rupture, severe bruising, thin, translucent skin, and joint hypermobility. The overall management of EDS mostly has to do with monitoring and treating complications. Obviously, it's a genetic disorder. There's not a lot you can do to change that part of it with medical treatment, but there's things to keep track of with monitoring, and if there's any complications that result from the syndrome, you treat them. So things that would be common are that they would need physical or occupational therapy to do more of a supervised exercise. These people cannot partake in more high impact activities. Having musculoskeletal type pain would be very common due to the ligament and joint issues. They can have anxiety or depression, and they might need to see a variety of different specialists depending on what organ systems are involved in their case. They could also talk to a geneticist if they don't have a clear diagnosis of the subtype, or if they're thinking about having children. There's a lot of potential complications. The pregnant patient, so they would need to be aware of those complications, what to look out for. They have a higher risk of premature delivery from cervical insufficiency, higher risk of premature rupture of membranes. They should be followed by a MFM specialist, and they should be monitored closely, during the third trimester, given those risks. Pregnant people have ligamentous laxity already, regardless of whether they have genetic syndrome, so that's obviously increased even more in these patients. Vascular EDS patients specifically are at high risk for uterine or other vascular ruptures. They say the mortality is estimated around 12%, just from being pregnant and having this syndrome. And they say to avoid spinal or epidural anesthesia, I assume because of the risk of injury or things not closing up when the needle is introduced to that space. And then after delivery, they've increased risk of postpartum hemorrhage and uterine and bladder prolapse. So just to recap the management, it's individualized based on what their needs are. You want to treat their blood pressure aggressively to avoid risks, and surveillance of their vascular tree by either ultrasound or angiogram on an annual basis. I wasn't able to find exactly what that means because there's a lot of potential studies you could do, whether it's brain, neck, abdominal or thoracic aorta, or down in the extremities. It was a little unclear on exactly how far to go on the recommendations there. And then the overall prognosis for these patients in some forms, like classical and hypermobility, the overall mortality is the same as the general population. But vascular EDS is increased chance of mortality. They say 80% of individuals experience a major event of some kind by the time they're 40. So the median life expectancy is 48 years in vascular EDS. And then kyphoscoliosis form, the lifespan would also potentially be decreased by restrictive disease. If their scoliosis is bad enough, it can constrict the lungs and their overall ability to breathe. The strongest predictor overall of functional decline is the number of organ systems involved. So if they have eye problems, heart problems, if they have gastrointestinal problems, all these things put together kind of pile on more and more of a demand from their body to react to. And these are my overall references that I used to put this together. Have any questions, thoughts, anyone?
I'm going to address Jill's suggestion about what's happened at the hospital. Ryan, it's good presentation. Thank you.
Thank you.
Don't go away.
Okay.
So they can hear. Just to give you an oversight, that the general problem with this individual is his cardiac status and in and out of heart failure. So that is the main issue that's life-threatening for him. The overall problem with that is the potential of infection from the dental work that he needs in terms of compromising his cardiac morbidity if he had surgery. So the cardiac surgeon doesn't want to do the surgery until the dental issue is resolved. It's been very challenging, and I can tell you that Lisa has done a yeoman's job. I've tried to help as best I can to try and accelerate the process of how we get the dental issue resolved. What sounds very simple is not very simple. And most of the oral surgeons that we've talked to, most of and the hospital that's been involved with us, Longwood was so generous that they were going to do this patient for free if we could find someone to do it. And the risk involved in this particular patient with this kind of major dental work is serious, especially since he was in heart failure 2 weeks ago. And so people are afraid to really get involved. And I was talking to Lisa yesterday about when you reach a point in patient care that you've run out of options with serious disease, you feel like you've been defeated. That here we are to try and give the best care we can to patients, and yet the obstacles in our path with this particular patient are humongous. The last input I got from one of the hospitals was to send him down to Miami and let him go in the emergency room down there, and they'll have to take care of him. I mean, it's a traumatic way to do it, but it is a step that we possibly could do. If I could contact someone in the emergency room to let them know that this patient's coming so he can get the adequate care that he needs. But as I was telling Lisa yesterday, the prognosis, as you saw, I mean, Ryan did a nice presentation on that, is limited. And especially these vascular patients with cardiac involvement, their prognosis is very poor, and especially if they're going in and out of heart failure all the time. We're treating a symptom, can't treat the disease. Can't treat the disease because you can't fix his heart because of his teeth. Can't treat his teeth because of his heart. It's tragic. It's just tragic.
Ehlers-Danlos is repeated surgeries to fix what breaks.
Yes.
Much.
Yeah.
So they're, it's genetic, so it's with them at birth. But if they have one of the milder collagen type, perhaps it's not diagnosed early. How would someone in primary care, what would you look for to possibly consider? And my second question would be, with the collagen type of Ehlers-Danlos, is there also the issue with the vascularity, but to a lesser extent?
So, yeah, to answer your first question, in this case, the patient came to us with already having a diagnosis. His mother had the same diagnosis, so that made it easier in that way.
I'm
But
just thinking if you're in primary care.
yeah,
The question is, if a patient shows up to you
yeah,
and you're suspicious of it, what can you pick up on physical exam that would make you
Right.
want
I
to
think-
evaluate this
I
patient?
think in medicine, we're just becoming more aware that this exists, that Ehlers-Danlos is there. And so there may be people walking around with Ehlers-Danlos, a milder case of it, that have not been diagnosed. And so, I mean, like the joints, hyperspasticity, and the other interesting thing that I thought that as you're doing your patient histories, if you have a parent that had early cardiac death, at an early age, then look and see if their fingers spin backwards. I mean, because it could have been the vascular form of Ehlers-Danlos.
I'm going to answer that.
Sure.
I think it's more common than we think in our physical presentation.
Yes,
This particular patient has the vascular
right. No,
presentation,
I'm just trying
which
to
is
think,
totally different.
right. It's, for a milder form of the disease, if it's undiagnosed, how would we recognize it?
How do you diagnose?
I mean, you just have perform as Ryan went through, bending the finger back, the skin elasticity, the elbow. I mean, you can't bend your elbow beyond 180 degrees, but they can. So these are things that make you think of the mild form of the disease. They have a big heart murmur and they have those symptoms. That's an entirely different patient that has a poor prognosis that needs to be evaluated. But most of the ones that are mild do very well. There's no shortening of their life. They do quite well. In fact, they show it off. They show off what they can do and say, "Can you do this?" kind of thing.
What kind of genetic testing though? Can you say
Yeah,
genetic?
like
What
labs.
kind of genetic lab that you can
Yeah.
pick up on?
There is specific genes that they look for,
right.
that are markers for the different types.
Because you said there's 13 types.
Right. So they have to distinguish that and also like compare it to other connective tissue disorders or Marfan's. They're kind of along a lot of the same spectrum, but just with different genes. So I've never actually referred anyone to a geneticist. I don't know if anyone else here has, or how that works.
Right. So if you have a relative like his mother, if you can't identify the particular gene, you can do what's called RFLP, which is restrictive length polymorphisms. So you can find out what she's carrying and identify that he has the same thing. You take that a step further. If a patient presents to you with known EDS and says, "I want to have a child," besides the risk of all the pregnancy issues that Ryan went through so thoroughly, we can now offer pre-implantation genetic diagnosis with IVF, so we can have an unaffected embryo that can be transferred into a surrogate or back into her if she wants to assume that risk. So the evolution of this is that if we can identify it, we can give them options in terms of stopping the progression of it. And I do think that as time evolves, and I'd be happy to give you a talk on this on CRISPR, which is putting in a new gene where there's a defective gene to stop that transmission. That's on the horizon. That's not a new frontier. That's really on the horizon.
Scary.
Yeah.
It's a little scary, but so you guys know that with your DNA molecule that spins down, you have two genes. And so when you're making a baby, it splits in half, and half of your genes make the baby and half of your partner's genes make. And so if you have, with this one, you have one gene that's got EDS and one that doesn't. So you got a 50-50 shot of your kid having it. So now we can figure out what the good gene is. So here's a question for you. You have EDS and you have a child, and your child does not have EDS. Can that child pass EDS along to their children?
Can they be a carrier?
Right? That's a trick question.
It's not a
First of
trick
all.
question, and you're wrong. You either
Wait,
get
wait,
the gene
wait.
or you don't.
You're talking about
Recessive or
autosomal dominant,
gene.
that's an autosomal dominant disease. That unaffected cannot pass it on. But a
Correct.
recessive,
Yeah, I didn't say that. We're talking about dominant gene.
okay.
So
all right.
if you, so you've got the good gene and the bad gene, right? So if you, you have a child and your child does not have the disease, okay? So they got the good gene. Well, yeah, and with their partners, right? So, but the gene you gave is a good gene, right? Everybody following me? You've had this already. Can they give the gene that they don't have? That bad gene stayed in mom. So the good gene is what was donated. So, so can their children get EDS if they never got the bad gene?
So if they have the good gene, then no, they're not.
Correct.
good. It's
Not
Yeah.
from you, perhaps from another
From
partner.
the
No,
husband.
I'm gonna tell our audience that we're gonna sign off. Thank you all for participating and hope you learned something today. We'll see you next Lunch and Learn next month. Bye-bye now.